Welcome to the Ty Beal Show, where we discuss food, science, and life. I'm Ty Beal, a scientist at the Global Alliance for Improved Nutrition, or GAIN. My guest today is Dr. Sara Brungardt, a leading expert on OCD. Dr. Brungardt founded Calm OCD and has dedicated her career to treating OCD. In our conversation, we cover the fundamentals of OCD and touch on eating disorders in adults. A quick note before we start. This podcast is separate from my role at GAIN. Okay, let's dive in. Dr. Sara Brungardt, welcome to the show.
Thank you so much for having me. I appreciate it.
So you're a leading expert on OCD, and we'll talk a lot about that today. You own a private practice really dedicated to treating OCD. So I'm interested to know what got you interested in this and inspired you to devote your whole career treating OCD.
Oh, goodness. Yeah, that's a good question. People ask me that all the time. So I've been a therapist since 2011. I did general mental health for a while. And then when I started my PhD, I really got excited about treating eating disorders. I was working on a college campus and I had an opportunity to treat a lot of athletes with eating disorders and then ended up writing my dissertation on the topic. And so I just kind of loved that field. When I moved out to Arizona, I had planned on working at a private practice specializing in eating disorders, but I found another OCD, or I guess a new OCD clinic that was opening at the time. This was back in 2016. And I was like, this is an area I truly know very little about. And it was so interesting to me. And I didn't learn about it in school very, very much. And I met with the director at the time, and I would still be able to do a lot of my eating disorder work in conjunction to learning about OCD and treating that condition. Mm-hmm. So I started that and worked at that clinic for 5 years. And then I started Calm OCD. Goodness, it's been open 4 years now. And so we've been open 4 years. And so I just kind of loved the intersect between those two conditions and got really passionate about both of them.
Wow. It's inspiring that you were able to sort of make your career out of something that you didn't fully learn until after graduating, right? After school.
Yes. And I'm really passionate about training other therapists and psych MPs and physicians and psychiatrists about, most importantly, how to screen for OCD, because I had no clue and I made a lot of mistakes in knowing how to screen for OCD and classifying it as a condition that it wasn't. And so I did not have adequate training in graduate school, in my PhD program. You know, in a lot of those programs, it's general mental health and not specialized service. And so all of that came after.
Yeah. Well, I'm really excited to learn more about this. I'm curious myself, and I know a lot of listeners are as well, because I think we hear a lot of, at least I do, and I kind of share, I'm just being OCD. And I really want to hear, what is the difference between having traits of maybe perfectionism, being particular, somebody who's maybe really hardworking? Like, how do you distinguish between those where you would consider those as sort of like very common in most people versus somebody who has the condition of OCD?
Yeah. I think this is a topic that I could spend 40 hours on answering, that question. So I think I look at many different factors. One of the things that comes to mind is I'm looking when a client comes in and I'm looking to kind of narrow down a diagnosis, I'm wanting to know their previous treatment. Okay. And so if somebody has been in treatment for anxiety for a very long time and they've tried so many different types of therapy, they've tried hypnosis, they've tried EMDR, they've tried CBT, maybe just traditional CBT without kind of, the evidence-based stuff that we can talk about later.
Mhm.
They've done that with very little to none relief. That's something that kind of is a caution flag for me, is people that have been in anxiety treatment for a very long time.
Okay.
The number one thing I see it as misdiagnosed as is generalized anxiety disorder. And so with generalized anxiety disorder, things tend to be a bit more free flowing. And so if somebody has anxiety and fears around certain things, maybe giving a class presentation or um, life changes or even death or something like that. A lot of times, if the life change has happened or the presentation has happened, that anxiety diminishes after they have completed the trigger
Mhm.
or after, their loved one passes away, they're able to grieve and that anxiety slowly dissipates. That is different than somebody with debilitating OCD. So somebody with OCD, you're going to see major themes. So they're going to have major themes that drive their behaviors. They're treated very, very similarly, but with OCD, we're looking for these major themes, and I always use the word relentless. These
Mhm.
themes are relentless. And so, I remember working with somebody years ago that had false memory OCD, and they actually had that subtype for 50 years.
Wow.
And so their brain was bringing attention to a fear that they had done something bad, something wrong, and harmed somebody. And so there's also this flavor of harm subtype. And then the compulsive behavior they were doing was spending so much time mentally reviewing and doing all of these different mental rituals to try to gain clarity and to reassure themselves that this feared outcome didn't come true. And so that is so different than somebody with generalized anxiety disorder, where, and I'm not trying to dismiss somebody's experience with GAD, but it tends to kind of move and groove throughout life. It shifts and changes, where a lot of times these subtypes that people with OCD have, they're so all time consuming that it's years and years and years of debilitating pain.
Wow. Okay. So it's really pervasive across their life over time. It's not just a general, like natural response to somebody dying or a hard, difficult life event, right? This is something that's distressing continually. Um, I'm wondering about. I've heard this other term, obsessive compulsive personality disorder, OCPD. And can you tell us about the difference here? Like, how do you distinguish between those two conditions?
Yes, I'm so glad you brought that up because I was actually going to bring it up. So, treating OCPD is actually kind of my newfound love, and so really within the past 2 years, I have just done a better job kind of learning more about the research behind this condition, learning how the treatment looks different than when we're treating somebody with OCD. So if we look at the statistics, so somebody with OCPD, it is likely that they also meet the criteria for OCD.
Mm.
Okay. But not all the time. I've treated folks that have OCPD and then likely a GAD flavor. Um, an OCPD diagnosis is interesting because I would say that diagnosis is missed even more often than OCD. So somebody with OCPD tends to be very high achieving. So these often are CEOs of companies. These are specialty medical doctors. These are certain specialty anesthesiologists. They tend to be very high achieving, and they tend to be very perfectionistic. There is a strong anxiety flavor around the perfectionism, and there can also be an element of intense control over themselves as well as their loved ones. And their willingness to come to treatment is a little bit I should say much harder. It's much harder to get them in the door. So it's usually a loved one that brings them in for treatment, or they come in for treatment because of OCD or depression. With OCPD, people are doing their behaviors because heart of hearts, they truly, truly believe that the behaviors that they're doing are warranted and that there's nothing wrong with them and that they should continue to do them. It makes sense. It's very rational. It's very logical. Like, why wouldn't I stay at work till midnight to check my charts? Why wouldn't I make sure that my kids have done their homework and maybe even redo their homework for them? Like, why wouldn't I do that? So it's a different treatment because they truly want to be doing those behaviors. Where somebody with OCD, they don't want to be doing their compulsions. And we define compulsions as any type of behavior that somebody is doing to eliminate the distress that the obsession or the fear causes. So people avoid with OCD. They avoid using public restrooms because they don't want to have to do their compulsion. They don't want to wash for hours and hours.
Mm-hmm.
So that's different than somebody with OCPD, where to the core of their being, they believe their behaviors are justified and they should continue them.
Which it takes, the spouse saying, please help. This is driving me crazy before they recognize it, maybe.
Yeah. So treatment for that, I would say we utilize lots of different treatment modalities to kind of get the buy-in. And I would say that, they're in treatment a little bit longer just because we're addressing a personality piece. And it's usually been there for decades and decades and decades. And so we're asking them to make changes to something or lots of things that they've been doing for so long. And that is not easy.
Yeah.
And so there's a treatment called RODBT, radically open DBT, that helps individuals lean into flexibility. And that's also a treatment that's used in eating disorder treatment a lot as well. And so that is something I recommend. And then we use a lot of kind of traditional CBT, so cognitive behavioral therapy, where we're looking at restructuring thoughts and restructuring a belief system that's been there to the core. And what's a little bit unique about OCPD and the treatment I do, I spend a lot of time really on understanding their family system, their early family system. Most of the time, they've had a parent that also is controlling in a certain way, and I will say this personality just has this essence of over control. And so I do spend a lot of times kind of going into the family work and seeing if it's, one of the parents that likely has had OCPD.
Okay.
And then one of the other things that's really helpful for the buy-in is really helping them understand how some of their behaviors may be impacting their loved ones.
Okay.
Especially their children. And I don't want to create this cycle where their children are highly perfectionistic, and that leads to over control, that leads to anxiety, that leads to eating disorders. So that's kind of a little summary.
Okay, really insightful. I'm wondering, does a person with OCPD, do they also sometimes not even have generalized anxiety disorder or another condition? Like, do you ever see them not being really distressed? They're sort of happy with their life, but it's the people around them that are having problems, or do they usually have some sort of distress going on in their life?
Well, uh, they may be okay. They may be telling themselves that they're okay with how they're functioning because that's how it's always been. So some of these qualities I can even see in a 7, 8, 9 year old. And so it's perfectionism is still driven by anxiety. I always, tell my clients as a recovering perfectionist, I didn't know as a kid and my desire for academic performance and, looking a certain way, that was all driven by distress.
Yeah.
And so there's this mind body disconnect in these folks where they they're so used to being so on top of things and being, the head of the school board and the head of all of these things that oftentimes they don't realize that they've actually been experiencing anxiety their whole lives. And so
It's just normalized.
that'd be my argument there.
Yeah.
Even if they don't meet the criteria for GAD or something like that, what happens is if somebody with OCPD and I'm giving them a challenge, and this is something that wouldn't happen right away, but say I'm giving them a challenge to not stay late after work and to go home at 5 p.m. like everybody else, that is going to create anxiety for them. And so that I already know that to be the case. And
Mm-hmm.
so it's when we pull some of those behaviors and we start adding some flexibility in how they function that you're going to see that anxiety. But I'm also tying it into what we call acceptance and commitment therapy and doing a lot of values work. And so I understand that your brain wants you to stay until 10, 11, 12, 1 a.m. checking charts and making sure things are perfect and going over emails. But I'm wondering what you could do with your kids tonight instead. I'm
Mm.
wondering where you haven't taken them for a while. I wonder if we can put something on the calendar. And that's really where I kind of go to get the willingness piece, where your brain is saying this is super important, which makes sense. This has been 40, 50 years of this. But I'm wondering if we can build some new, pathways of understanding that you can actually build relationships. You can actually build stronger connections. You can have hobbies. So a lot of times they don't have any hobbies. It's all kind of achievement driven.
Yeah. So it's maybe tapping into what are their real values? What do they care about? When they're older and they're at the end of their life, what are they going to sort of regret if they don't do it? Maybe I'm hearing like aligning the choices and behaviors with those values to some extent, where this achievement is the top priority. But really, if they think about it probably deeply, their family would come first.
Yeah. Yeah. I love to kind of go into, I understand that you have the desire to stay late at work, and it's okay to have that desire, but we actually don't have to listen to every message our brain tells us because every message our brain tells us is not accurate at all. If I listened to everything my brain told me that I couldn't do, I would not have accomplished anything in life, right? Like I
Hmm.
wouldn't have done any higher education if I just listened to what my brain told me.
Right.
And so I think that's a key part in it too.
I like that your private practice is called Calm OCD. I'm sure that was intentional. You have been talking somewhat about evidence-based care. You've been talking specifically about OCPD. Shifting to OCD and maybe your kind of typical case, I'm sure there's a lot of variation. Uh, there's these methods that you have talked about where it's exposure response prevention or ERP, and then you talked about acceptance and commitment therapy or ACT. What do you typically do, and how do you take someone who has a debilitating case of OCD that is controlling their life, interfering with their well-being, their happiness, causing them a lot of distress and anxiety? How do you start, and how can you offer for listeners who may be struggling with that? How can you give us some hope that, okay, this can actually be overcome? It feels probably impossible at the start for people.
And it's great that we're even doing this episode this week because next week is OCD Awareness Week. And all we do is talk about hope. Uh, I could talk about this again. I think, it's interesting with our clinic, we see people at all varies or variations of severity. So we definitely, see mild, moderate, But what is most common is really more of the severe or extreme presentation. People that call in or people that are even on our website, sometimes they truly feel like their OCD is so significant and too bad and that treatment won't work. I can't tell you the amount of times that I heard that. I know somebody that was on our website every single day for 90 days before they had the courage to submit an inquiry. It
Wow.
is really fear that oftentimes prevents them from reaching out. And then there's also this kind of belief that this cannot improve. And it makes sense because almost always when you have severe or extreme depression, you're also going to have co-occurring, when you have severe or extreme OCD, you're going to have co-occurring depression.
Mm.
And so there's this level of hopelessness. And so when people start treatment, especially if they are doing like an IOP, so an intensive outpatient program where we're seeing them 15 hours of individual therapy a week, typically for 3 weeks, but we can do longer. I've done longer IOPs. But when you're at that level of care, I think even on day one, they are very suspicious of us. They do not believe that their life can look differently in 3 weeks. And the reason I pretty much only do IOPs anymore because I prefer more of the complex presentation because I like to get in there and treat it aggressively.
Yeah.
And so that for that first day, a lot of it is psychoeducation. Sometimes people have this belief, and maybe they've been on Reddit or something like that and seen very poorly done exposure response prevention. They think that they're going to be thrown into these, really horrible experiences, and that's just not the case. And so, whether it's an IOP level or single session level, probably about 5 hours at least of psychoeducation on OCD, and then bringing in their loved ones so that they're understanding their role is key. And so that kind of builds a strong foundation. And then we're kind of going into different skills that they can use to start talking to their brain, kind of understanding what it would look like to start resisting compulsions. And so all of that kind of lays the foundation before we do exposure response prevention, which is primarily what we use. We also use a new evidence-based, I guess within the past year, newly evidence-based treatment called inference-based CBT. But for the behavioral therapy, for the ERP, I just want people to know it's not something that we're shocking their system at day one. It is something where I wouldn't even, entertain the idea of doing exposure therapy until you understand, how your OCD cycle works, how your obsessions and compulsions work, what mental compulsions you're doing. All of that is laid out prior to doing the exposure therapy.
I can just imagine like a severe case of OCD. If you're meeting with a therapist 1 hour once a week, that has to be incredibly challenging. What you're saying is this intensive outpatient program every day, probably, or multiple days a week, several hours a week for a long period, a lot of education first, and then going along with that momentum, having enough volume of treatment to really stop be able to change the course of what's happening. I think for those who maybe aren't able to get into that, do you sort of encourage, if you have a severe case of OCD, you need to do this, you need to be in here intensively, or do you have alternate routes where people can still
Yeah.
get treatment, but just on a more manageable timeline?
Yeah. So usually when we do a phone consultation, we have an idea of what we would recommend treatment wise. If we need more information, we'll schedule an intake session and then kind of make a recommendation. So if an idea of somebody with extreme OCD would be somebody that, a kid no longer going to school, an adult no longer working, or if they are working, they're still doing compulsions all day long during the workday and then at night during the workday. And so I'm looking at like how it is affecting their entire system. And so typically those would be the ones that would be appropriate for an IOP. If it's somebody at maybe low severe or even high moderate, if we can treat it at, we can give it a shot at 2 or 3 times a week. I've done that. I always tell people we can always switch. So if we start out at single sessions and then it's not enough, we can always move into an IOP.
I think it really helps when a patient, for anything, whether it's somebody going to a doctor for a health condition, going to a nutritionist for something, going to a therapist, they really want their practitioner to have confidence that they understand what's going on and they can treat it. They have that experience. And I think what you're offering is that we have seen patients who felt like it was impossible. This was not, I can't get over this. This is no way. And I'm afraid to even start. And I think the confidence of having had numerous patients come through with really severe OCD and actually recovering and getting to a place of much more stability and ability to have a fulfilling life. I think that probably means a lot to people when you can sort of speak with that confidence.
Yeah.
I think a lot of, you said at the beginning of this, a lot of clinicians or maybe therapists who aren't, if you don't get this training, right, in your typical schooling, you don't learn these things unless you do this training and you intentionally seek it out. So what are some maybe telltale signs that clinicians or even the families who are, may have kids or family members that have something that we kind of miss? Is there sort of the key things that you sort of can see, like, oh, this person was referred to me, this person came in, nobody picked up on the OCD?
Yes. So I get a lot from, again, just current symptoms and current functioning. So anybody that comes in our door, and I've trained some college, campus mental health centers on the fact that really anybody that's coming into a clinic needs to be screened. Anybody that's coming in for anxiety really needs to be screened for OCD.
Mm.
And so that's what we do. We kind of normalize that process. And so we have a symptom checklist that they're going over. And then the therapist is going through that and asking follow-up questions to see, like, does this meet the criteria for OCD? Or maybe did they not understand the question? I'm not going to take the symptom checklist and be like, yes, you have OCD, without asking follow-up questions. But I typically, I can make that, distinction typically within 60 minutes. Sometimes it takes a few sessions. Another thing I'm looking for is major themes that happened in childhood. So, for example, if an adult comes in for OCD treatment and it looks like, okay, yeah, they are experiencing some obsessions, and then I'm going way into childhood. And I'm asking just about anxiety because that's how they've kind of normalized it. Yeah, I've just always had anxiety. So I'm like, tell me more about that anxiety. Major themes in childhood. It's fascinating. So any school avoidant case or any time there's been absences with school and high school anxiety, I'm screening for OCD. And they have a lot of obsessions around fear of intruders. And so then they want the parents to check locks at night or give them reassurance. Any type of rituals with like stuffed animals or toys to prevent something bad happening, excessive prayer, stuff with numbers and words are common for kids. I mean, they could be there for adults too, but I'm looking at that to see what's going on. I remember having somebody, that I think I was their 15th provider, and I finally gave them the OCD diagnosis. And once we went into childhood and I learned more about some of these things going on, I'm like, oh my goodness, this is an OCD diagnosis for sure. And so there can be contamination stuff, extreme perfectionism with kids. There can be kind of interesting ones where they fear of blurting out obscenities or insults or doing something inappropriate. Concerns around safety, all of those things I'm looking for and asking about.
It seems pretty challenging probably for people who aren't trained. If a person who, this is probably a rare case, but 15 or 16 providers and you were the first to really diagnose OCD, kind of tells you there's there's maybe a shortage of awareness even among providers or therapists. So I know your population probably, obviously you treat OCD, so like most of your patients are having some form of OCD, but do you know in the general population, like in the US, if that is something, where the prevalence of that, like can you rely on the data on how many people we think have OCD? How do we know?
So they've recently, I mean, kind of shifted it to 1 in 40 individuals. And so when I do trainings at other clinics, I'm reminding them that's 1 in 40. I'm not saying 1 in 40 in a mental health clinic. So that's even higher that are coming in for anxiety or sleep issues or relationship issues.
Hmm.
And so I think that would be interesting data as well. And I I definitely think that's probably, pretty reasonable, pretty spot on, or even a bit higher. If anybody asks what I do for a living, it's super interesting because people either say that they have OCD and they'll talk more about it, and I'm like, oh goodness, like you're not using it as an adjective, like you definitely do have it,
Hmm.
or they have a loved one with OCD and are familiar with it. I do think the education around the diagnosis is getting better and better. There's still a lot of ways to improve it, of course, but I do think that that statistic is probably fairly accurate.
Okay. And even like you said, even higher among maybe the population that goes to therapy for other conditions. I can think of like in all conditions, so this is not just OCD, but when you either yourself experience something that you've experienced for a long time, it could be OCD type traits, it could be ADHD, it could be whatever. It's easy to normalize it as, oh, this is just how everyone is. Or if you have a family member, maybe you have a kid or you have a spouse, a partner, and they behave a certain way, it's easy to probably just almost just get used to it. Where I could see there being a underdiagnosis because it's sort of like, oh, this is just the way things are, and you don't really think about, oh, this is something that has a very clear definition. There's a very clear treatment. This can actually improve this person's life. Do you see when you're working maybe with kids, parents, or families? Do you see any sort of families inadvertently accommodating compulsions? How does that play into it?
Yeah, that's one of my favorite things. I guess I have lots of favorite things, but that's definitely one of them is working with the families. So when people bring a kiddo in and we maybe make a diagnosis of OCD, usually one of the parents realize that they actually have the condition too, and it's usually for the first time. I will say that would be the norm. Sometimes they come in saying, I have OCD or I have OCPD or I have both, but it would be more typical that somebody comes in. I go through the psychoeducation, or one of my therapists goes through the psychoeducation with the kiddo and the family, and then parents start reflecting and realizing that. I think with older generations, maybe, it's normalized and people maybe have always taken like a sleep aid or something like that because they couldn't shut their brain off. Or they've been called like worry warts or different phrases when really once they learn the psychoeducation piece, they're like, oh my goodness, I have OCD, I think. So it's really quite common for us to see sometimes 50% of a family unit. So we at our clinic, so we may start with the kid and then start with, one of the parents or both the parents or a cousin, because of the genetic piece to the condition. In terms of accommodations, yes. So there's a curriculum called Space where and I mean typically it's designed as something to utilize with kids, but I use it with adults as well and working with parents of adults with debilitating OCD. But it's really a curriculum that helps people start reducing accommodating behaviors based on their loved one's OCD or anxiety condition. Because in the moment, these families have done everything they can to try to not trigger their child, to try to alleviate their child's anxiety, to try to make everything better. And really, it's creating kind of a perfect storm for the OCD. And
It's
so
reinforcing it.
Yes, so the individual's OCD gets larger and larger and larger because their world has gotten smaller. So the school avoidant piece. And so I've done a lot of trainings with school counselors where, you know, I don't want one of my clients to have, they have like passes where they can leave the classroom whenever they're feeling anxious or something like that. I don't want my clients to have that. I'm such a big picture type person that I'm looking at overall development, overall social cues, in 10 years when this person's going to college or when they're in the workforce, they can't just say I'm anxious and get up and leave the meeting. Like that's not possible.
Right.
I want to be careful and not generalize here. There's definitely exceptions. If somebody is, has co-occurring, level 2 autism or something like that, there would be exceptions to this, of course. But
Mm-hmm.
for the most part, I'm not having the kiddos flee the classroom anymore. So we actually go to the schools and help the teachers and the counselors reinforce these skills because every time that kiddo flees the classroom because they have a fear of vomiting or a fear of doing something wrong or they made a mistake, it's reinforcing the brain's idea that that's something we need to fear rather than I need to stay in this moment and realize that my anxiety is likely going to come and go. I can feel this uncomfortable emotion.
I think that's really wise, and it probably applies beyond OCD of doing the hard thing. Think about it in parenting, where it's very easy to just give in to try to avoid the distress, to try to minimize the immediate distress in the short term, if it's anxiety or emotion regulation or whatever. And it's really important to sort of, you can handle this. I don't need to remove all of the stressors, right? It's more being present for them in those distressors. And you're saying across the life, so in the school, the work environment, at home, in all contexts, you really have to set up the environment to where you're sort of exposed. You have to face the distress, because in life, you can't just, as you grow up, even if you're an adult, you can't just get out of things. You can't just walk out in the middle of a meeting, do whatever you feel like to avoid the anxiety or the distress. Do you see a lot of comorbidities, other conditions with OCD? I'm thinking things like ADHD. You talked about generalized anxiety, other conditions. Are there sort of the most common things you see alongside OCD?
I would say the most common would be ADHD, autism, generalized anxiety disorder, sometimes PTSD. We see um, what we call BFRBs, which are body focused repetitive behaviors. That is skin picking, hair pulling, any type of that type of condition. That's essentially a self soothing tool that the individual's using. Co-occurring misophonia, which is issues with sounds, usually something with chewing or um, crunching or someone
So
using a pen or
I have to
something
stop
like
you there,
that.
because that from the moment I can remember, I have had very intense misophonia.
Yeah,
I even
yeah,
discovered the word when I was a child. But
yeah.
my family can tell you I'm much better now. But I would not be able to handle certain mouth noises at certain times, especially in a quiet room, chewing,
There's,
that kind of thing.
yes, and
Yeah.
there's usually targeted people, and then there's usually targeted snacks and food that they dislike, or, they don't like dad coughing, or they don't like mom sniffling. It's you still can't officially diagnose it, and so it's not even in our diagnosing book, but it's definitely a thing. I think it's misdiagnosed as OCD all the time, and once they come in, I'm like, no, 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 this is not OCD. It is a completely different condition, and the treatment looks a lot different. So we actually get people from all over the country that come for treatment for severe misophonia. When we're working with severe and extreme misophonia, sometimes those kids are no longer living in the home, or they're no longer and they're no longer going to like a traditional school anymore.
Yeah, I can imagine. Um, so for treatment, you've been talking a lot about behavioral stuff, therapy, do you also use medication? Is there a role for medication, and how do you sort of decide between
Sure,
medication?
sure. Yeah. So I refer to the experts, the ones that went to medical school. But when somebody comes in with severe or extreme OCD, I do have that conversation where research has indicated that medication can do wonders for the OCD brain. So usually when you're at an IOP level, I would say most do a combination of the behavioral therapy and the medication. And the SSRIs are typically what physicians are prescribing for this population. What's really important and why I do so much training with professionals about screening for OCD is because if you don't have an OCD, that correct OCD diagnosis, people are on the wrong medication. So people come to us and they are on a very, very low dose, which is not enough, or on a medication that has no research backing it for OCD. So then we typically refer them to a medication provider that we feel comfortable that's well versed in OCD. So that's another reason why that diagnosis is so important. And typically, the physician is going to increase that medication to a therapeutic dose, even beyond the FDA recommendations for very extreme cases. I have seen that. It's not always necessary, but sometimes you have to do what you have to do in order for this person to, to function. But so I would say, the majority of our clients are on medication like Zoloft or Prozac or Lexapro or Luvox. Those would be the common ones. But a lot of times people are having great results with just the therapy piece. And so, especially if kids come in and, maybe they have moderate symptoms, like let's see how far we can get with, therapy, the individual therapy with the kiddo. But what's actually more important is a therapy with the parents. Let's see how far we can get with those interventions. We can always, see about medication later on, always have that referral available.
Yeah, I like that you kind of emphasize the parents, because I think in a lot of therapy for children, it really is the parents. And I'm saying that as a parent, as I've sort of learned, like usually the answer, the solution is changing the parent. It's through the parent, right?
Yes. I always say, I only have a limited time with your child. Like you are with your child far more often than I am. I need to give you like all the skills that are in my brain. I need to teach you them. So at an IOP level, in some cases, so we see them 3 hours a day. So I may do 90 minutes with the parents and 90 minutes with the kid. Like that's how much I'm doing because they may be accommodating in very subtle ways that I have to point out. So, an example, say we're helping parents of an adult with OCD, and say one of the tasks I want for the adult with OCD to do is maybe to get on LinkedIn or Indeed or ZipRecruiter and start applying for jobs. So say they come, that's the assignment. They come back the next day or the next week. Come to find out, dad has talked to all his friends and said, "Hey, does anybody have a job opening for my kiddo?" And they may see that as, I'm just using my resources, I'm just trying to help it, which I get, but I'm really wanting the young adult to go through all the stages of getting a job themselves. They're having to face different fears and different OCD related fears, maybe some social anxiety pieces. And so I want them to practice that independence and for dad and mom to step back. And so there's these subtle things that, parents or even spouses, they'll come in and say, I'm not accommodating, I'm not accommodating. And then we pull back the layers and I have to point out the subtle ways they're accommodating.
It's probably just a lot of misunderstandings and a lot of psychoeducation. People can't consistently do what they need to do until they really understand those subtleties and those nuances.
Absolutely. And just
Yeah.
reinforcing over and over what the long term goal is and what goals they have for their child. And so, say it's a teenager, maybe a 15, 16-year-old. Okay, so if we want your child to move out of your home in 2 years or 3 years, what daily steps do we need to start taking in order to make that a reality? Because the way your teen is functioning now, it's not possible, but what do we need to do on a daily basis? And so very, goal oriented steps every day.
Hmm. So, do you have you've mentioned a few myths or sort of misconceptions. Do you have if you could just clarify for listeners, even for clinicians, what are some of maybe the most damaging or the most problematic misconceptions or myths that are really you wished you could just sort of set straight?
Yes, I'm trying to figure out where I want to start. I mean, the major one is just people really understanding the depths of the condition. I think is one of the top five most debilitating conditions. I mean, folks are on long-term disability because of OCD. A lot of times, if a loved one can't relate to the person struggling with OCD, they'll get really irritated and really angry and say, like, why don't you just stop? Like, leave the bathroom, quit showering, quit washing. Like, nothing bad is going to happen. I think people have to understand, like, the person struggling with OCD, their fight or flight system is being activated 24/7. It is being activated by the slightest thing. So their brain is telling them to do something, and it makes sense that they're doing what their brain is telling them. I mean, any human would do that. And so again, it comes back to the psychoeducation and them understanding that really daily life things like driving, like doing laundry, taking a shower, getting dressed are very, very difficult with severe OCD, and especially if you haven't had quality care yet. And so I think just kind of what people view OCD is, and maybe view people as lazy and not having good work ethic if they're maybe always late to work. It's not that they're lazy, it's because their brain is telling them to pay attention to other things. A lot of times with OCD, the brain has a lot of false alarms. And so these folks with OCD are following all these false alarms because their brain is telling them to, essentially.
Yeah. That makes a lot of sense. I can understand. You can understand why somebody who doesn't know about OCD can get frustrated or upset. And I think being a bit more of an awareness of the condition and that it's not personal. Like it's not like somebody's trying to do this stuff to be, in any way sort of mean or lazy or whatever. And it's like nobody wants to be in distress. So it's just very clear if and when they can see a way out, of course they would want that,
Yeah.
right?
Yeah, nobody would choose this, no
Right.
matter the subtype. Say a child has obsessions around the fear of poisoning someone. So that means that they don't um, even they can't do daily chores. And so they can't put food on family members' plates. And the parent may say something like, well, why do you have that thought? Why would you even think that? And so if a parent says that, I'm like, oh, yay, like that's a huge education time. Because the OCD brain is going to give them these triggers, going to give them these major themes. Your child is not choosing this. No, nobody would choose to have a fear of poison. And so sometimes they'll be aggravated, especially if it's more irrational or more kind of in the magical thinking type area. Sometimes they're like, that doesn't make sense. You aren't going to poison someone. You're not going to harm someone, something like that.
Yeah. Yeah.
Something else I would say is just the subtypes of OCD. People focus on the checking and contamination part of OCD, and those are the most well known. And I would say what we see the most at our clinic would actually be harm and sexual based obsessions. And so, what's fascinating, and I always give this example when I'm doing trainings about all the mistakes I made early on in my career. When I was treating and doing general mental health and not adequately screening for OCD, there was a period of about 3 years I was working at a clinic. And during that 3 years, I did not have one client tell me anything about harm or sexual obsessions. That's not because they didn't have them, it's because I didn't ask.
Uh, knowing what to ask, just like the education in the general clinician or therapist.
Yes, if we're not asking the right questions, we're not going to get the right answers. Somebody who has never heard of OCD or they don't know that they're experiencing OCD are not necessarily going to tell a therapist that they're having horrific sexual intrusive thoughts about their new baby, or they're having harm-based thoughts and fears about throwing their children or driving over their children. They're not going to do that because of fear of judgment and a fear that the therapist will call Child Protective Services or the police. And I've known therapists do that were not well informed with OCD. The difference is that it's fear based. This is not a pleasurable thing. They're absolutely terrified that they're going to do this. They don't want to do it. So I think that's one of my other things is people just really understanding the depths of it. The depths of it and contamination and checking are definitely debilitating. I've seen that at all levels. But there's these lesser talked about subtypes that deserve a lot of attention as well.
So can you just dig in a little bit more to that? These like sticky thoughts. I think probably most people have some sort of thoughts that are unwanted or obtrusive, and they come and they go. How do you distinguish between somebody who has OCD? Is it like the thought doesn't leave, it's repeated, it's consistent, it's what is it? Like where does a threshold for that?
Yeah, I love that question. I kind of normalize that everybody gets random intrusive thoughts. And the difference with an OCD sufferer is they will receive that intrusive thought. They will have more of a physical, emotional response. It may feel like anxiety. It may feel like irritability, but also shame and guilt. So that emotion may also come up, and that has to be explored as well, especially when it comes to harm and sexual based obsessions. But then what the OCD brain says is we must do something about this. So there's a sense of urgency that this needs to be figured out. So I received an obsession. So an obsession is any fear, worry, or doubt. Could be an image as well, any intrusive thoughts. So that comes into my mind, and then I have an automatic physical response. And then my brain tells me I have to do something about it. So the phrase I have to, I hear a lot at the beginning of treatment. I have to check my phone. I have to drive around the block to make sure I didn't hit the little girl playing soccer. I have to wash my hands an hour after preparing meat, or whatever that have to looks like. Anytime they use that phrase, we know that they're getting ready to do a compulsion. So the main difference is that the intense emotional response from that intrusive thought, and then them wanting to do a compulsive behavior to get rid of the distress.
Right.
There's also this flavor of the OCD brain being super critical and wanting to find meaning. So it may say something like, oh my gosh, you had this horrible thought about hitting that person. What kind of a person are you that you'd even have that thought? Somebody without OCD, if they had a harm-based thought, their brain would say, oh, that's weird. That's bizarre. And then they would keep going about their day.
Right. And I think for people listening, I think it's easy to be judgmental of like, oh, how could you have those types of intrusive thoughts? But it's like these people are probably the last person to do those things. Their brain is just so overactive. Like, did I hit the kid? Did I what? It's about this compulsion, right?
Yeah. It's things very dear to their heart. Even if we look at kind of postpartum OCD, a lot of times there's some contamination stuff. There's some safety concerns. It's about something that matters the most to them, right? Something that is the dearest to them. One of the things, and I know you didn't ask me this question, but I think it may be important to highlight, there's a lot of books out there about kind of labeling OCD as a bully. And, there's books out there for kids about it and adults about it. And the longer I'm in this field, I strongly kind of dislike calling it a bully. And that's where I kind of enter in kind of acceptance and commitment therapy, because I don't want somebody to be angry and mad at a part of who they are. And OCD
Hmm.
is a part of who they are and a part of their brain. And so I love to come from this lens of kind of self compassion and understanding that yes, it totally sucks that your brain is focusing on these things. But I want you to understand that your OCD brain is actually trying to protect you. So it's trying to protect these feared outcomes from coming true. So if it says, don't hold your child as you walk down the stairs because you may purposely drop your child, it's trying to protect you and saying, no, 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 don't take the risk. And so people through treatment learn to have a different relationship with their OCD. They're no longer a victim of their OCD. They're seeing it as kind of this, overbearing sibling, so to speak, that's kind of pestering them, that they're like, thanks so much for the heads up and the warning, but I actually don't need to pay attention. And
Right.
so I think that's an important part in healing and, moving from extreme OCD to mild OCD.
That's a good point. You don't want to feel like you have a bully as a part of your identity, and you can think of it more in a sort of healthy, compassionate way. I know a lot of folks, probably even listening, may have OCD, and maybe they couldn't afford treatment, or they didn't get it when they were younger. Do you have any sort of tips for how do you sort of address this if you're low on money? Like, how do you find do certain providers take insurance? How can you get treatment in a way
Yeah.
that's sort of accessible?
I would say there's so many great social media options nowadays, and so many great resources via Instagram or TikTok. That would be honestly a great place to start and to learn, especially if you are on a wait list. A lot of times with quality care, and it's in a specialty clinic, there is a wait. And so sometimes some of those kind of YouTube channels or even there's so many great OCD podcasts out there can be a great place to start. And I have people do that a lot. The International OCD Foundation website, if you go to that website, you can scroll down to, I think, location and then click your state, and you can see what options are available per your state. So even down to if they have support groups for OCD, if these different providers take insurance, if they're cash pay, you can kind of see that. So that's a great directory for folks. I do tell people that if you are thinking about getting treatment, do not hesitate. Even if your child, for example, just started exhibiting symptoms and you're like, oh, I'll keep my eye on it. I can't tell you the amount of times that I'll see somebody at our clinic and I'm like, oh goodness, I wish I would have seen you like a year ago or 2 years ago. And so please reach out as soon as possible. Most OCD clinics do not have immediate availability. And so call and get on a wait list. I always tell people, even if you're on the fence and you don't know, call a bunch of places and get at least on a wait list to start.
That's great advice. And it sounds like maybe, the ideal is to go to a really great practice, and I hope you do it sort of intensive way. But if you can't afford that, you can't get into something like starting somewhere, learning about that, doing some of the psychoeducation, getting into support groups, and then finding if there are practitioners that take insurance, or you can have maybe more affordable options. Um, you, Nutrition is also obviously a big feature of this podcast, and I'm curious about. You had this PhD, you focused on eating disorders in your dissertation, and you said that sometimes you see this sort of overlap. Are there any sort of food or nutrition types of things that overlap with OCD that you see in your practice?
Yeah, my first thought is how much time do we have left? So if you were to guess how many people with OCD also meet the criteria for a clinical diagnosis, what would be your guess
Clinical diagnosis of what? Oh, of
of an eating disorder? How many people
um,
with OCD
I'm
have
gonna guess 20%, one in
so
five.
it's 1 in 5.
Is that right?
Um, I would predict it may be higher. There's some major themes that I see that I've seen over my career, and so I'm only really speaking to that and kind of what I know of
Hmm.
the whole population. With if we're looking at an OCD diagnosis, we're looking for an overlap of if it's somebody that meets the criteria for an eating disorder. Of course, they could meet the criteria for binge eating, for bulimia, for all different. But the major ones we see would be anorexia, ARFED, orthorexia. Um, yeah, those would be kind of the top three I think we see. So you're going to see, because of the personality style of an OCD individual and kind of that over control, we're typically seeing more of this restricting type behaviors. Even if somebody doesn't come in with a clinical diagnosis of an eating disorder, there's lots of disordered eating present. I would say the majority of the time people are not eating often enough and they're not eating enough. And they don't really understand how much nutrition their body actually needs and how often they need to be eating throughout the day. That would be the most common thing I see.
Okay, I'm very curious about this because many of my colleagues or not just colleagues, but if you think about sort of the community of kind of passionate health people who really are, biohackers, if they're into like fitness and nutrition, I would imagine there's quite a high prevalence of maybe this orthorexia. Like, how do you distinguish between somebody who's just really healthy and they're really into their sort of diet and exercise in a sort of generally healthy way versus somebody who's like doing that in a way that would classify as orthorexia? I need some
Yeah.
education here. How do you distinguish?
Yeah. When I train my staff, I always say the phrase like it depends, but it depends on so many different factors and me kind of fully assessing, the client, of course, but some of the things that come to mind um, is just kind of a overall flexibility with food. Are we able to be flexible with what we eat? Are we able to be flexible with the types of food we eat? Or is there a pretty, anxiety provoking response to that? If so, we would be definitely wanting to lean more into the flexibility piece.
Mhm.
You can't technically diagnose orthorexia yet, but I think there's definitely space for it. And at our clinic, the majority of the time somebody comes in with orthorexia, we're likely making an OCD diagnosis along with it. The
Okay.
very, very strict rituals around the portion size may or may not, have a body image component, but more about the clean and safe eating. And so, I'm kind of trying to understand what's the orthorexia and what's the OCD type behaviors.
Right. That makes sense. I think there's probably also a case that there's sort of I think there's a group of people who eat a certain way because they have some sort of health condition.
Mhm.
And that is different from somebody who's eating a certain way because they're obsessed about, I have to make sure I only eat these foods. I don't eat, whatever it is. I don't eat gluten, or, if it's vegan, I don't eat any animal products. And it's like, they're ethical reasons to do things, but it's like in general, as long as you're not having an extreme, like a big health reaction to something, having more flexibility, which I think we probably in my community needs to hear. Like, we sort of strive for this, you got to have a healthy diet. You got to make sure you eat all this stuff and you don't eat this and you cut out this. And I think it can be to an extreme, right? Where
Yes.
it loses sight of the bigger picture of overall health and
Overall
well-being.
wellness.
Yeah.
Yeah, we're strong at our clinic. We don't have any food rules. And when we refer to dietitians, that kind of align with how we feel and adding flexibility in people's food and the time that they eat. And so we're looking for a lot of any sort of ritualized behaviors, right? Like I have to eat salads for every meal, and then after that, I have to take a walk. That's something as a clinician I would press back on, and adding some flexibility with that. Whether it's some related fear of, I just don't feel well, or is it a fear related to weight gain, or is it a fear related to I won't sleep? That's where I'm understanding where to go treatment wise would be based on what the fear is, because it'd
Hmm.
be different for everybody. One time I had somebody that said, well, I don't really know why I do that. I did that because that's what my mom did. So I thought that was interesting too. And so we can kind of press back on kind of their own belief system around food. One of the telltale signs is that rigidity of how we view food, good and bad, how we view sugar intake, how we view all of that is something I would press back on quite a bit.
Hmm. Yeah, that's the thing. I think I think about a lot. Like, is this food good or bad? There's a lot of, I think, perspectives where it's like, oh, there's nothing wrong with saying that. Like, we're just trying to say this is healthy or not. But like, there is also this aspect of what the way I think of it is as in my field, we do care about the nutritional value of foods for a bunch of different reasons, but there are different purposes of foods too. Like some foods provide a lot of nutrients, other foods can provide a lot of sort of a cultural experience, a social thing with friends. There's so many different ways that foods nourish us and our well-being beyond just the nutrients they contain. So I think that sort of shifting from this sort of this is good, this is bad, don't eat this or don't have too much of that. I think we get carried away in the nutrition field.
Yes, and I do see that a lot. Since I had mainly treated college athletes, with eating disorders, and a fair amount had OCD too. There's so many similarities in terms of like the ritualized behaviors. One of the things that I forgot to mention earlier when you had asked me co-occurring conditions with OCD, but there's body dysmorphic disorder, and we could spend 2 hours on that.
Hmm.
Also, a lot of panic disorder. But if I speak to body dysmorphic disorder, the misconceptions about that condition are that it is something that people struggle with, like females struggle with, that teens with anorexia struggle with, or people in hospital settings struggle with. There's this misconception that body dysmorphic disorder has to look a certain way or in a certain body.
Hmm.
The majority of body dysmorphic cases I've treated have actually been in older males, and it's been concerns with areas kind of from the shoulders up. So the hair, over concerned with the hairline, the nose, skin texture, ears, and then especially in kind of the fitness industry, all of the hyper concerns with wanting the muscles to look a certain way, but wanting to be lean in a certain way. With body dysmorphic disorder too, the body part that they're concerned about can shift and change. And
Mm.
so these people may be hyper concerned with something on their nose for a while, and then it moves to their legs or something like that. And so that there's a strong overlap there in the body image piece too.
That's really insightful. I think that's something that probably is a misconception where we sort of think of anorexia or women when we think about eating disorders, which is of course common, but there are so many probably that are maybe even not or underdiagnosed because the sort of population, maybe men, are less likely to sort of go and get treatment or admit certain things, right? I think there's a bit of a barrier there as well. I'm sure I could pick your brain about this forever, but I want to respect your time. I just have one sort of final question is when you think about all of the different clients you've had, you don't have to get into any like identifying details, but do you have maybe a particularly memorable case that taught you something really important about OCD treatment?
I don't. I'm gonna kind of generalize it a little bit. So I think the longer I've been doing this work, I have learned that I don't necessarily need to have, like, in as I show up in session, I don't need to necessarily have a plan for what that session is going to look like. And when I train my staff, I say we have to do a better job of listening to what our clients say, and they will tell us the direction that we need to take. So what I find in kind of poorly done exposure therapy is, they'll log, if it's telehealth session or something, they'll log on and the therapist will say, okay, this is on our agenda today. We faced this last week. We're going to face this today. Well, maybe not. See what your client is presenting with, what is showing up for them, and that'll tell you the direction that you need to take. And so I think, as I've done this a long time, just needing to hold space for what my client needs, I would say, especially at the IOP level, I'm pretty relentless and it's pretty taxing, and they're exhausted after meeting with me daily. And sometimes I can read the room where I'm like, okay, this person doesn't need to do any homework today. Like, this person needs to go and sleep and relax and watch a good movie. Like, they need to press pause. And so I think one of the things I've learned the longer I do it is treatment looks different for everybody. And so I can give you a general idea, but we're going to pay attention to what you need to.
That's great. I love that. It's sort of like an attunement, like making sure you're really aware of what your clients' needs are, where they're at, because you got to meet them where they're at, and prioritize their state, their agenda, what they need, as opposed to sort of coming at it from, this is what we're going to do. It's not a one size fits all approach.
No. And where do I need to spend more time focusing? Where are they confused education wise? It's not all about the behavioral therapy. It's about learning, how can I manage this condition, and how do I learn to invite and embrace, these triggers, and have a different relationship with my OCD.
Yeah. And it sounds like you have to be a good listener as a practitioner to really do a good job. Well, Dr. Sara Brungardt, it's been a pleasure. Thank you so much for speaking with me today.
Yes, thank you so much for the invitation.